Thank you, Fred. A lot of that discussion will lead neatly in here. So I guess some of this is repetitive, but it's sort of hammering home the point, I think, for ourselves. There's my conflicts, and nucleus is obviously the one that's key here as speaker fee. So I think I would perceive we do need to change the situation in bladder cancer this year, currently for the future, because I think we have problems with it. These are the UK survival data for the disease, okay? So we focused a lot on non-muscle invasive disease, but what drove us in the UK was that the outcomes from aggressive disease are not improving the way we would like. Centralisation has made a big difference in the UK that may or not be applicable to other healthcare scenarios. But fundamentally, we aren't improving the survival of this disease, which is, in contrast to nearly every other solid cancer out there at the moment. So we feel that things need to change. This is the outcomes from cystectomy in Sheffield year on year, and you see there is no real trend. It's all over the place. So it doesn't really help us at the moment focusing so much time on this disease. This is the same graph as you showed, Fred, and again, it reiterates the point about the cost. And I think partly that is because we are spending the money in the wrong place. So this is the cost versus the mortality rate. We spend the vast majority of the cost on bladder cancer monitoring low-grade, low-risk disease, and very relatively little on chemotherapy and radiotherapy, where all the mortality occurs. So we have to somehow change that shift that momentum. And I think a urinary biomarker like this gives us further opportunity. Why is it so expensive? Why is it so difficult? It's because it's so complicated. This is just the diagnostic pathway. We know we have hematuria. We're bringing together a number of specialties together. And that's, if you find someone who needs, thank you, Fred, more aggressive treatment, then suddenly you're going to have a whole range of other choices that come their way. So in the UK, even in what we think is a target-driven culture, this can take around 100 days on average now to go from the beginning to the end. And I think that must be contributing to part of our story. And then afterwards, when you look at the recurrence rate and the progression rate and the surveillance, again, we're looking at huge amounts of resource and infrastructure to look after a disease that probably doesn't kill many people after the first phase and the first rationalization. And that leads to poor quality of life. So this is the NHS Patient Experience Survey. This is a survey across all people with cancer, a sample from all of them. And what you find, as you'd expect, is the urological diseases do badly. And maybe that's partly because men have a slightly poorer affect, whereas women don't. But predominantly it's to do with the fact that there is a lot less interest in this end of the disease. And there's a lot of repetitive cystoscopy and follow-up with limited impact on their survival. And if we look at, so that's patient experience. If we look at their patient-reported outcomes, so this is to do with how happy they are, we see that a lot of them have problems with self-care, a lot of them have problems with mobility, and those lead to problems where you have to come repeatedly to and from hospital. So I think all of this feeds to a culture where we have to think about changing how we manage some patients with bladder cancer. If you add those up together, that's what you get. So my focus has been often, as at the moment, to try and shift it away from the green, the low-risk disease, and shift our energies onto the yellow and the red disease through trials, improving treatment. And thankfully now we have new drugs, new advances, that this is actually now happening finally for bladder cancer. But we have to refocus our effort, I think, slightly off the green situation here. We've looked at this work and we took low-grade cancers and we found very low risks of recurrence. And that matches what we see elsewhere. So this is the Swedish data where they look at pun lumps and low-grade papillary urothelial carcinomas. They represent about a fifth of cancers at diagnosis, and they have high rates of local recurrence in the bladder, 50 to 60%. So they're going to recur, Theo, if you follow them long enough, okay? But very few progression rates. This is the Sheffield cases, so again, it represented about 20% of our workload. Our recurrence rates were very high, but our progression rates were very low, 2.3% over the first 10 years. That was progression to upstage and up into invasion and then subsequent metastasis, etc. So it's low, and of those, you could break them down into a third where we got the diagnosis wrong up front. They clearly had an aggressive disease, and this is effectively the same as the false negative cystoscopy. We've missed what we were treating. Some gradually got worse over time, but a significant number, a third, we heard nothing from for 5 years, then suddenly the disease got worse. And when you spoke to these patients, they were having problems. They were having hematuria, they were having urinary symptoms. but because they had this annual cystoscopy, it didn't occur to them to tell their doctors that things were getting worse on the way through. And our data are nice in they match a lot of other series almost identically. So our disease-specific mortality was 2.3% at 10 years. That's almost identical to the Swedish data at 2.4%, identical to the US data at 2.8%, and very similar to Shirok's data from across a number of European sites at 1.2%. So it's a low event rate, and this is very similar probably to the survival from low-volume Gleason 6 prostate cancer over time, and low aggressive early-stage renal cancer. And we're very comfortable watching those much less aggressively than we do in bladder cancer. So I think the time is right to do that. I'll just shift. And when you break it down economically, it turns out to be a hugely expensive resource, and that's why we have these problems with the cost. So for all this triage from our initial cohort through, for all the effort, we saved one life by all the surveillance we were doing in our 2.3% mortality rate. It took 7 flexible cystoscopies to find a recurrence, 147 to find a grade progression, between 375 and 675 to find a stage progression, which effectively meant we were spending about £2 million to save one life. And that is a simplistic quote. That doesn't account for all the extra burden on patients coming to and from hospitals, antibiotics for urinary infections, admission for hematuria, pain, all those things you can imagine. So it's a lot of money that we are not spending elsewhere that we are spending on this disease, and it reflects time and effort. So in NICE, we recommended much earlier discharge. So discharge at 12 months if you're stable. But for many reasons, this is not necessarily acceptable and has not been adopted by many of our patients. In Sheffield, we worked together, we worked up a compliance pathway, and we found that we were saving 30 cystoscopies per month if we adopted that pathway. And our patients seemed happy. We did patient surveys, there wasn't much decision regret, people were happy with it. They came back in, and with time, some of those patients will have cystoscopy. They're not lost forever, but we are trying to shift the burden elsewhere, okay? But as Hugh will show in this meeting, when we do a survey across the UK, less than half of my colleagues have adopted this because of the things we talk about, Fred. They are uncomfortable with the concept of discharge. Patients don't feel comfortable with it. And it's something new that's different to what we've done before. So people are unkeen on that. So perhaps somewhere there is a middle ground that we can come up with, and that's maybe where urinary biomarkers could be there. If we look at the burden, so Fred, your fantastic guidelines group, and the whole guidelines in general, if we look at what they recommend for intermediate risk non-muscle invasive disease, this is the number of cystoscopies you should have over the first 10 to 15 years. And it's quite a burden if you think about that, especially if you are traveling a long way for the patient, especially if you're elderly and you already have mobility issues or something. So it's quite a burden that may not necessarily affect their outcome, especially if you look at these event rates, they are stabilizing by 5 years or so, if not sooner. So, do we need to follow on lifelong? Do we need to reflexly do an annual cystoscopy? I don't know. But what about biomarkers? So up to date, Fred did a very good summary. I think the perception of many people is that historically they have been unreliable. They are not as good as we think. And when we hear from patients, maybe 90% in the Netherlands, certainly in the UK, if you ask the patients and you give them the impression of a fantastic cystoscopy, they want a very high rate, 100% accuracy or more. And they're expensive because often they merely duplicate the effort, nearly always have to do cystoscopy at the same time. But I think there are some opportunities, some low-hanging fruit, where maybe we could work together to try and bring them in a way that is safe, is acceptable, and probably is cost-effective, okay? So that's the way we work it. So if we take low risk, this is the current guideline option. This is cystoscopy to 5 years and then discharge at that stage, depending on demand. So what about using a biomarker to alternate? So Fred, we have a discussion at this stage. What would you think of that approach? Would you be comfortable with that for your patients? Okay, should we have a show of hands? So in the room, who would be happy omitting alternate flexible cystoscopies in a patient who was asymptomatic and then swapping it for a biomarker? And if the biomarker, nuclex in this case, was positive, you would then do an on-demand cystoscopy. So put your hand up if you would be happy with that approach. Okay, and then put your hand up if you would be unhappy with that approach. So only one, which means I have to ask you why. Yeah. Oh, he wants to go to the toilets over there. So I can understand some patients would be uncomfortable. Andrew, could I ask you as a patient, what would you feel about that approach? So this is in low-risk disease first.
I think if
Okay.
that if you get stopped at any point, you're taking a big risk.
Yeah.
And that's the zeitgeist out there, because that's what we're told by everything we read and talk about without any guidance from you guys. So you've got to change the conversation so that we realise that this burden we accept isn't really giving us any benefit or very limited benefit. But at the moment, we can see without regular hospitals for life, people who are getting the worst treatment. That's the massive amount of over-treatment.
Okay. So I'm going to look at some people in the audience. Yuan, can you stand up, please? Do you perceive that in Spain, low-risk patients are happy with, do you use active surveillance at all? If you find someone who's had a low-risk tumour, you look in, they have a smaller piece or they're asymptomatic, would you just watch them at that stage, or would you think, reflex, I should TUR or cauterize and remove all burden?
To be honest, I don't know exactly, but what generally speaking are doing in Spain. As you know, there are a few groups doing active surveillance. And also there are centers that do just small recurrence, just for outpatient fulguration, which takes a few minutes and that's it. So there are exactly how many groups are doing one thing or the other, I cannot tell you. Okay. What I can tell you is that a lot of people, I think in Spain, we are following these low-risk groups just with ultrasonography. Okay. And nothing happens. So, and we have not published it, but we have promoted, and really just following these patients with really low-risk, low-grade tumors, ultrasonography. If you not detect a 2-millimeter tumor, nothing happens. And when it's 5-6 millimeters, you see it, and then you treat it. So, and I think this is an option in a urinary marker meeting, probably, or to combine in the future. I don't know exactly which methodology, or to combine ultrasonography plus marker or whatever. I don't know, probably. Okay. But basically, I don't have the evidence, we haven't published that, so, but nothing happens. But there are also 2 studies, I think, 2 Danish studies they published following patients with ultrasonography compared to cystoscopy. And
but if you do cystoscopy, do you combine that with cytology? Because you might miss CIS or...
Yes, in so low-risk group is just ultrasonography. In intermediate risk group, we combine every 6 months ultrasonography and cystoscopy cytology.
So it's basically a similar schedule as doing a test with a high negative predictive value, but then with different means.
No, probably using a marker with a high negative predictive value, you don't need to do ultrasonography, you need to do cystoscopy and nothing. I mean, with a very high negative predictive value.
Now let me, I have some doubt to use urine test in a very low risk population, because if you look at the first line of the ERTC trial, with the patient with recurrence score 0 and progression score 0, so this very, very low risk population. So which is the adding value of urine test in this population during surveillance? Probably we can change the cystoscopy interval without adding any other test, because the 15% of the most of the recurrence is during the first year. Yeah. After the first year, there is so if you use 3 months cystoscopy, 1 year cystoscopy, and then after 2 years cystoscopy, we can.
Yeah, I think the only reason I pick on this is that we tried to change the cystoscopy interval in this cohort from once a year to never again, and it wasn't really accepted by patients and doctors in the UK. And okay, every 2 years, but you know, there's good work in other cancers that show that routine follow-up actually can lead to worse outcomes, because patients develop symptoms of a problem and they go, well, I saw Dr. Witches last year, he said don't worry about it, and they don't represent to you. So actually, in other cancers, there's good work to say what you need to do is educate patients about the symptoms you would worry about, and then ask them to present earlier with those symptoms rather than ignore them and wait. And so we thought in the UK that may be the better model to try and educate, but it doesn't seem as acceptable, whereas something like this, I think people would still feel under a safety umbrella about that sort of thing.
He's first, actually.
Sorry, I was just having my supper earlier on. Okay. Sorry.
So he was the yes.
I was the yes, because first of all, I'm from the UK and very happy using the nice recommendations for low risk groups. We see them 3 months, 12 months, no recurrence, discharged. So I'm very happy with that, and our patient population seem happy with that because we put it them early on that that's what they expect, and that's what we do, and educate them about when to come back to us. My understanding is that all these biomarkers, the sensitivity is much lower for picking up low-risk tumours, and so really, if it's a low-risk tumour, the biomarker isn't going to pick them up anyway. And if you are going to look for something with cystoscopy or ultrasound, you want something that's small and easily diathermable. So I don't think they're going to add anything in the low-risk group.
I think the only thing is that once you start doing this to populations, then the 1% progression risk suddenly becomes 100 people, you know, and so this is a way of trying to maybe reassure that's the case. Now, I suspect those 1% would be having hematuria and a change in their urinary symptoms or something like that would help trigger it, but yeah.
Yeah, so just explain myself rather than hide
No.
my sandwich.
Andrew.
I think that we've got to look at the actual discharge protocol for any patient, no matter whether they are low, intermediate, high risk, or even muscle invasive. Because at the point of discharge, you've got to actually counsel the patient and then counsel the GP of what that actually means. So it means that they have to be told and empowered about what to look out for so they can actually come back to you. Because what this isn't is about goodbye, we'll never see you again. It's about empowering the patient to actually be aware themselves of what symptoms that they might get so that they can come back in to see you guys. Because that should happen all the time, because there's this false sort of belief that by checking on this regular basis that you can ignore it in between times. I mean, we do know that patients need to be empowered so that if there is a particular symptoms they're getting, they should come back to you between checkups anyway. So, but it's about empowering them with the right information so they can be part of their surveillance. That's where you'll get the better response, because they'll be there in front of you at the right time rather than waiting for that year interval or 3-year interval or whatever we say in the chart.
So if I take another model, so let's move off in low risk. I think low risk is probably the low-hanging fruit in that I agree the biomarker will probably be negative, but I think it is the group that is safest to trial some sort of biomarker in because the event rate is really in your favor. But if we go into the bigger population, which is intermediate risk, and of course there are high and low intermediate risk, and there are ways to risk stratify. But again, currently this is the EAU guideline approach. And I wonder either about an alternating strategy, where you save maybe 9 cystoscopies, or a swaps strategy after a period of time, whether that be 3 to 5 years. My worry about this sort of strategy is that this is where the false positives become important, Fred. I know Ellen Zvortov did the Uromol study, where they did a study prospective in Rotterdam, I think it was, where they did urinary biomarkers in one arm and cystoscopy in the other arm, and you got on-demand cystoscopy if you were positive in that arm. The problem was the biomarkers were positive nearly all the time, and at the end of the study you had far more cystoscopies in the biomarker-driven arm than the control arm, because actually these people have got field change. Perhaps they have field change that's not quite amounting to a cancer, and we don't understand the biology enough, but there are some molecular changes that certainly don't ever propagate through to a malignancy. And this is where the false, whilst when you're looking at diagnosis, it's the negative predictive value you want, i.e., if the test is negative, are we sure they don't have cancer? And this is 99% if you look at high-grade disease. But in the long term, you also want some specificity, because it means that if the test keeps going positive in patients who don't have it, you're going to be bringing them back just as much.
Yep. Oh, that's why we want to know what the results are of the negative, positive predictive of the false positives.
So should we have a show of hands in the room then? So, I mean, you don't have to agree with us, but would you feel comfortable in a more higher risk population? So intermediate risk here, so not high grade, not T1, but probably relatively high volume, low grade disease. So if you look at the ERTC, you know, more than 3 centimeters, multifocal, maybe some recurrences early on, but nearly always low grade recurrences. Who would be comfortable in sort of alternating cystoscopy for a biomarker in that setting? So much less so. And who would not be comfortable with alternating a biomarker in that setting? Okay. And the rest of you are to be convinced. What do you think, Fred?
I think it all depends on the performance of biomarker. We're just asking imaginary study. I would be happy taking biomarker in any scenario if it performs according to the needs that I need in that scenario.
Well, you were late. You missed in so we have the biomarker pilot study that's shown at what is negative predictive value 99%.
Well, you said nucleus as a biomarker.
Yeah.
That's a different than a biomarker.
Okay. Well, this particular biomarker.
Okay,
then.
sorry.
So, Shirok, what do you think about this?
I think in this scenario, I think I haven't seen the presentation, but it depends what you expect in this scenario. You want a high negative predictive value. That's the one thing you care about mostly, right? And the nucleus does very well in this scenario for the low-grade cancers. So it's probably, and even if it's not 100%, if it's 80%, 85% in an intermediate risk, you're happy with that. In the high risk, it's different. In the low and intermediate risk, you're fine with 80% above. No?
I think we want safety for patients,
Right.
but we also want to try and improve or reduce the burden of surveillance on them. Okay, so I'm going to close there and let sort of wrap up. Let Shirok come in. Is Shirok next? Yeah. So I think there is an opportunity here. I think you can pick safe cohorts to trial biomarkers in. I think we have some interesting models where we could try and reduce the burden, and I think mostly we would still feel comfortable with that. And I think patients would buy into that because they feel that they're still going to get that surveillance and they're still going to have the gold standard, but if they're doing it less often. So I think there's an opportunity to go from. So thank you for your time.